Hi everybody, this is our next section in Chapter 2 in the rheumatology section. Section 2 is seronegative spondyloarthropathies. Seronegative spondyloarthropathies basically means ankylosing spondylitis, axial skeleton, axial skeleton, axial skeleton. You can think of it like that. Ankylosing spondylitis also means axial skeleton, doesn't it? That means vertebra, spine, and sacroiliacs. Reactive arthritis, the artist formerly known as Reiter syndrome, CNP. Psoriatic arthritis, ooh, I'm falling into the nails pit. Tales from the nail pit, psoriatic arthritis, yeah. And JRA, juvenile rheumatoid arthritis, because there's no blood test for that, puts it in this section. Okay, adult onset Still's disease, very difficult because there's no precise test. So in the diagnosis, remember, all of these have in common the fact that they're called seronegative because they have negative tests for rheumatoid factor. And they have a predilection for eating your spine and sacroiliac joint. Now, JRA goes in this section, but that one's not so much just eating the spine. JRA is here because it's seronegative. And there is an association with HLA-B27 for psoriatic, for Reiter's, and especially for ankylosing spondylitis. But I must caution you that the answer to the question, what's the diagnostic test? HLA-B27 is not to be used as an acute diagnostic test. We disagree with that. 8% of the population is HLA-B27 positive, and we disagree with the answer that says use this as an acute diagnostic test. Not true. Ankylosing spondylitis is an average delay of 2-3 years to diagnosis. A young guy is 25 and 30, walks in and says, "Hey doc, I got back pain, I got back pain." And you're like, "Yeah, go on, get out of here." 22 years old with back pain, go away. And that's why it's an average 2-year delay. Young, immobile. You see, what you never think about is that when you bend over, you should be able to get 5 centimeters of movement. You should be able to get 5 centimeters of movement. In the bend me over, it's now known as Schober's test. Don't you wish you had described this? That you had been the person that bent all these people over and you measured it and you're like, yeah, you should be able to bend over more than that. You only got like 3 centimeters out of that. Let's see that again. Here, let me stand behind you and bend, yeah. So the thing is that's what Schober did. And he basically said you're immobile in your lower spine. Your lower spine is turning into a board with no lumbar curvature. Turning into a board with no lumbar curvature. Peripheral joints are very uncommon. Ankylosing spondylitis makes everything immobile. The chest wall is immobile. You stiffen up overnight. That's how you know it's different from osteoarthritis. Osteoarthritis is peripheral joints out here, large peripheral joints out here in the hands, and it gets worse with use. Ankylosing spondylitis, you wake up stiff as a board, and overlay, you can loosen up. That's why it's worse at night and relieved by moving around. I like to move it. You like to move it. They like to move it, yes. And decreased chest wall expansion because they want to move, but they can't. And that's why you want to get the high grade. Maybe you're someone who, for a reason, you're looking for something super competitive and you're taking step 3 and you really want a high grade. Well, if you want to know the secret question for the 99th percentile, it is that ankylosing spondylitis has apical fibrosis of the lungs, apical pulmonary fibrosis. And we don't know why, but apical pulmonary fibrosis. Now, the decreased chest expansion is because, you see, that's why we have curved ribs, right? They're curved, they move around. But what if they didn't move at all? Decreased chest expansion, restrictive lung disease. Now, rarely, which is more common outside the spine? Is it the eye or is it the heart? The eye, the heart. And the more common one is the eye, 30% with the eye. Less common is the heart with aortitis. Okay, there's regurgitant lesion, aortic regurgitation. Restrictive lung disease from the chest wall immobility, and apical fibrosis. The 27-year-old man, months of back pain, worse at night, has diminished expansion of the chest wall on inhalation, and he's got flattening of the normal clumber, okay? What's the most accurate test? The most accurate of these is, bing, it's the MRI, yeah. It's not HLA-B27. X-ray of the SI joint is maybe the first test. X-ray of the SI joint is the first test, but the MRI is most accurate. The SED rate is generally normal, and by definition, the rheumatoid factor has to be normal, because that's why these are called seronegative spondyloarthropathies. Ankylosing spondylitis, eye, heart, restrictive lung disease, and unknown apical pulmonary fibrosis. The Schober test, bend over like a board, can't bend over. Now, treatment, non-steroidals and biologics. Now, this is one of the only things where TNF drugs is first. TNF drugs is first. One of the only things where TNF drugs is first. Ankylosing spondylitis, one of the only things where TNF drugs are first. And sulfasalazine. Now, methotrexate can be used, but steroids should not be. Steroids are bad news here. One, it's not that kind of inflammation. It's not that kind of inflammation. Steroids is wrong. Most common wrong answer. As a matter of fact, that's a Fisherism. One of the Fisherisms is saying what is the most common wrong answer for treatment? Steroids is wrong. Now, reactive arthritis. If the TNF inhibitors don't work for that, you should use methotrexate, sulfasalazine. Reactive arthritis, it's a classic, and this association with inflammatory bowel is correct, or especially GI infections and STDs, chlamydia, and asymmetric arthritis, urethritis, chlamydia, we don't understand what it is. It's basically an idiosyncratic disorder, we don't understand, but it really is associated with GI and urethritis, it really is. And you're tired, but it's too nonspecific, but the arthritis associated with genital lesions, circinate, cirque du soleil, cirque de balanitis. This is around the head of the weenie there, around the head of the penis, or inflammation of the inside there, because also it is urinary, eye, conjunctivitis, and keratoderma blennoragicum, which is a skin lesion characteristic of reactive arthritis, keratoderma blennoragicum. There's no blood test for it. So there's no diagnostic test. It's a constellation of symptoms of eye and genital joint, I see your joint and your genitals. And the treatment is one of the last remaining first-line indications for sulfasalazine, actually. One of the last remaining first-line indications for sulfasalazine. And if that doesn't work, you'll use TNF inhibitors. TNF inhibitors should go away, though. Now, psoriatic arthritis. Is psoriatic arthritis more common with more psoriasis? Does it go like a little psoriasis, a lot of psoriasis, a uber amount of psoriasis, and then arthritis? Not really. You can have it with even a tiny patch of psoriasis that you can't see. For instance, what if you had a tiny patch you couldn't see in the back of your leg there? People have to come in, they go, man, I got this nail pitting, and I got these pencil and cup deformity in my joint. Pencil and cup deformity, that's the question. Nail pitting, that's the question. SI joint involved, there's the question. And you're like, don't you have psoriasis somewhere? And people go, no, I don't have psoriasis anywhere. Well, what if you have a little patch of it on the bottom of your foot and you didn't see it? Or you have a little patch of it that is on your back and you didn't see it. You can have it with tiny little patches. And the key features are that you have nail pitting, and that there's distal interphalangeals. Remember, RA is with the proximal joint. RA is with the proximal joint. And psoriatic is with the distal joint. Psoriatic, RA. Psoriatic, RA. Psoriatic, RA. Sausage shape, dactylitis. Sausage digit, tasty, huh? Now, what is the name for the attachment point where your ligaments attach to your bones? The ligaments attaching to the bones, not the tendons. Tendons are where muscles attach to bones. Tendons attach muscle to bones. But what's the name of that point where ligaments attach bone to bone? They're called entheses. They're called entheses. And when you have an inflammation of that enthesis, it's called enthesitis. And they're of the insertion points of tendons and ligaments. Insertion points. Now, enthesitis or sausage digit, characteristic of psoriatic arthritis. There is no specific test. There's the most common wrong answer. There's our nail pitting. There it is. A little disgusting, isn't it? And what you're going to do is methotrexate. There you go. Because the non-steroidals are for pain, and then methotrexate to try and modify the disease. And then it becomes like the treatment in many ways of psoriasis. Well, psoriasis that's severe and widespread. The problem is you can't, for psoriatic arthritis, use light treatment. But you'd use TNF inhibitors and methotrexate. TNF inhibitors and methotrexate. Now, JRA is a constellation of symptoms. The closest thing we get to a test is what? What's the closest thing we get to a test in JRA? Not much, right? Well, there's leukocytosis, but leukocytosis is pretty nonspecific. But a high level of ferritin. Yeah, because of its inflammation. Ferritin is an acute phase reactant, like a white count, sed rate, C-reactive protein, ferritin, intrinsic cobalamin. These are acute phase reactants, like white count and sedimentation rate, C-reactive protein. JRA is the presentation of fever, usually fever of unknown origin. Why do you have that fever? Salmon-colored rash. Why are you having salmon? Salmon-colored rash. Make sure you eat some real salmon with salmon-colored rash so you know what we're talking about. Multiple joints, big lymph nodes, and muscle pain. Big lymph nodes and muscle pain, JRA. You're ill appearing, salmon-colored rash, high temperature, lymph nodes, and also a big spleen. JRA. It's very difficult to diagnose because big liver and spleen, that's not specific. Big liver and spleen. And there's no test. Yeah, you can have a high ferritin level, but even that's a sort of a non-specific marker of inflammation. The high white count, yeah. So you see the thing about JRA, you got to put it all together. Joint, rash, fever, white count, lymph nodes, and occasionally the very high ferritin level. Okay, it's very high ferritin level. Remember, if there's a positive ANA or rheumatoid factor, you're likely not going to call it JRA. That's part of the definition of disorder. Now, the treatment for this is nonsteroidals, and if the nonsteroidals don't work, the person comes in, they still have their rash and leukocytosis and fever and joint pain and high ferritin level. The next best step in the management of this patient is to use steroids. And then it becomes an unclear question of, after that, using TNF inhibitors and other disease-modifying drugs. Those are not clear questions. This is the clearest you can do. I will tell you, although only 8 to 12% of the questions on step 3 are diagnosis questions. What is the most likely diagnosis? About 8 to 12% of questions. Now, this is one of those that will be in that 8 to 12%. Now, 8 to 12% of questions for most likely diagnosis may seem small, but since most people fail by 3 questions, and excellence is another 5% or 10% of questions, that 10% of questions is to take the failing person into passing and to take the mediocre person into excellence easily. Now, if it persists and doesn't get better with the steroids, TNF inhibitors, methotrexate, JRA. Now, Whipple's disease is here because joint pain is one of the most common manifestations. It also goes along with fat malabsorption. So from a fat malabsorption point, it goes like what we're going to do in the GI section if you haven't seen it, which is oily, greasy, floating, flying stool, frothy, foul smelling, as if any stool smells good. And in addition to that oily, greasy, floating, flying stool, joint pain is often how people show up. But it's joint, eye, brain, joint, eye, brain. And I regret that it's a bit non-specific, but Whipple's disease is a profoundly rare disorder, but not rare on examinations, which is fat malabsorption with joint, eye, brain fever. Joint, eye, brain fever. And you see a biopsy that shows PAS positive bugs, or the new nifty thing is, the best initial test is stool for PCR of the bug, for the Tropharema repellii. Stool for the Tropharema repellii. Stool for the Tropharema repellii based on PCR. But its most accurate test is stool biopsy. The treatment is antibiotics like ceftriaxone or trimethoprim sulfa. And the great thing about step 3 CCS is step 3 CCS will take brand names. So if you don't know how to spell trimethoprim sulfamethoxazole, if you don't want to learn how to spell trimethoprim sulfamethoxazole, all you have to know is Bactrim and you'll be fine. Now, osteoarthritis is the most common joint abnormality we have. Morning stiffness is short. It gets worse at the end of the day. There's crepitus, and crunchiness. More distal. Remember, rheumatoid arthritis doesn't affect those distals. Rheumatoid arthritis does not affect those distals. And Heberden's nodes, these are osteophytes. They're osteophytes. You gotta remember, when you have stress on something, the body increases the surface area of contact, to decrease the stress. And Heberden's nodes are to decrease the stress by increasing the surface area. They're osteophytes. And Bouchard's are other osteophytes on the proximals. Proximal Bouchard's, distal Heberdens. I see Heberden in the distance. I see Heberden in the distance, and I see Bouchard up close. Now, the diagnosis, there is no blood test. X-ray will show joint narrowing because remember, most of articular cartilage is made of what? What is cartilage made out of mostly? Articular cartilage. Articular cartilage is predominantly made of water. So if you lose the articular cartilage, it makes the bones look like they're close together because you're losing the water content of the articular cartilage. You're losing the water content. So you see joint narrowing. Now, if you're on single best answer questions, you don't need any test to diagnose osteoarthritis. You don't need any tests. However, if this is a CCS question and you can order an unlimited number of tests and treatments, you should throw in that you make sure they don't have other inflammatory joint problems, and no one will fault you for throwing in the stuff to make sure you don't have inflammatory joint disease. Now, the joint aspirate is generally going to be normal. May show a few hundred cells, but I bet it's going to be under 2,000, because above 2,000, it starts to become inflammatory. But it's under 2,000 and often under 200. Under 200. The treatment, now it may seem like a small thing for you, but it's not if you're going to take it for a long time to come. The best initial therapy to treat osteoarthritis is acetaminophen, not nonsteroidals. Not nonsteroidals. Because nonsteroidals are going to rip a hole in your stomach. Did you know that at the end of a year, if you take an NSAID every day, like ibuprofen or Sulindac or naproxen, 20% of the people have ulcers? Now, they don't all bleed. The gastroenterologists are like, oh, they don't all bleed, man. Yeah, but it's like a hole in my stomach I didn't need. But acetaminophen has the same analgesic effect without burning holes in your stomach. Chondroitin sulfate is placebo. Glucosamine is placebo. They're not any better. Weight loss and exercise, because it's like this. If you're only carrying around a 140-pound you, it's not as damaging to your joints as carrying around a 240-pound you. So weight loss helps because it makes your joints have to work less. Exercise helps because the stronger your muscles are, the less work your joints have to do. You have low back pain? Do abdominal exercise. It takes the weight off, takes the stress off. Make your abdominals do the work. Your knee sucks? I'm sorry to hear that. Ew, terrible. You want to put off your knee replacement? Make your quadriceps stronger. Make your biceps more stronger. The stronger your muscles are, the less work your joints have to do. Just remember that this is the summary slide of the distance between these things. Pause and take a look for this for a second. Okay. Now, this is the end of this section. Just remember that the other part of this is glucosamine and chondroitin are not better than placebo. But hyaluronic acid injections are real. They are real.